Mediterranean ancestry. So this ancestry is very important. And the age is in patient is also important. Patient with jaundice, he also reports being usually tired. So tired and believes this may be due to his recent recovery from mononucleosis, infectious immune, because these people, they here you will see infectious mononucleosis also, and this is also one of the aggravating cause of this disease. He was found to be anemic with hemoglobin is this 9 gram per deciliter. His peripheral blood smear revealed bite cells. This is very important finding, and hinge body. These two are very, very important findings. Bite cells and hinge body. And I will tell you, anemia you can classify into 3 types. This is multiple of 4. You can see 4, 12, more than 12, then between 12 to 8. The gap is again 4. Okay, between 8 to 12, you can see 8 to 12. The gap is 4. Again, below 8. So this 3 classification you can do for anemia. This is mild anemia, mild. This is moderate, actually more than 12 and less than 14. Generally less than 14. So mild you can 13, in female you can take 13, in male you can 14. So this is mild anemia. So mild anemia is rarely diagnosed. Moderate, this is moderate anemia, 8 to 12. So you can see this is a moderate anemia condition. And when it is less than 8, it is severe anemia. It is regarded as severe anemia. So you can remember, this will be helpful. So this is moderate anemia you can see in such patient, and Mediterranean origin and attack of infectious mononucleosis. So this infectious mononucleosis, what it does, it actually create an environment of high oxidative environment. So this disease can create high oxidative environment, and because of this there will be damage to RBC and bite cells, hinge bodies are there. So this, what does this do? What is the diagnosis then? What will be the diagnosis?
G6PD deficiency.
G6PD deficiency. Whenever you see bite cells and hinge body, it is very characteristics of G6PD deficiency. PD deficiency. So this is very characteristic of G6PD deficiency. And if person is not exposed to oxidative stress, person is fairly normal. Little bit anemia will be there, mild to moderate anemia will be there, but patient will be normal. But when there is oxidative, any type of oxidative stress, whether because of drug or because of something else, some infection and other things. So in that condition, patient will actually have hemolytic anemia. And then what is the pathogenesis of this condition? So pathogenesis also I have described because of lack of production of low production of NADPH. Okay, you know, glucose 6-phosphate will convert into phosphogluconate, and this is the first reaction. If this reaction does not happen, G6PD does not happen, so there is no scope for this action of this. There is no substrate for the second enzyme, that is second dehydrogenase. There is no substrate for second dehydrogenase. But if this is present, this enzyme is present, even if this is absent, no problem, there will be production of NADPH. So that is why this first enzyme become crucial for synthesis of NADPH. Okay, and that is why glucose 6-phosphate dehydrogenase will cause this problem. So you can see the pathogenesis. So if you see this whole pathway, you will be confused. So as I have told you, just focus on the point. Focus on this oxidant formation. This actually oxygen-free radical formation inside the RBC, because you know RBC has many hemoglobin. Hemoglobin binds with oxygen, and that is why many oxygen. RBC is very much exposed to oxidative damage. Membrane of RBC is very much exposed to membrane damage, and because of that, there is chance of formation of peroxide free radical. This peroxide free radical will damage double bond that is present in the membrane. And before it damages this double bond of the membrane lipid and it breaches the lipid, this NADPH, where is this NADPH produced? This NADPH produced from this pentose phosphate pathway will actually nullify this. Nullify this. And there is an indirect nullification, not direct. That is why you can see complicated pathway. Actually, this proton will be taken up by glutathione, and glutathione actually nullifies this. So this is the production, and glutathione actually nullifies this. Nullifies this NADPH detoxifies this free radical through glutathione. Okay, through glutathione, and that is why this seems to be complicated pathway. Anyway, you can easily understand now. So you can see there are two enzymes. One is this glutathione peroxidase actually is the enzyme that has inside the enzyme, inside of this enzyme only this is glutathione is present. Glutathione is present inside this enzyme. You know, glutathione is tripeptide. Let me, this is very easy to understand. Peptide. This is tripeptide. Tripeptide means 3 amino acids is present here. So how do you remember this tripeptide? Because it has a glutamine. You can say what is glutamine? Glutamine is 5 carbon compound. So this is glutamine 1, 2, 3, 4, and then 5 carbon. 5 carbon, one is amino group. So you write it amino group here, and then you write O, and then NH2 group here. Thio means sulfur containing amino acid is cysteine. So NH16 is 3 carbon compound. So this NCC, okay, NCC, and here the cysteine will have got SH group. Cysteine will have SH group, and here thione means, just remember, glycine. So glycine is 2 carbon compound. N will be there and 2 carbon compound will be there. So I'm actually overwriting it. Don't confuse with this. So this is basically glutamine, and then cysteine, and then one means, what is the one? One is basically glycine. So here is sulfhydryl group. So this you can remember. I used to remember this as a bird with a beak. Okay, so there are 2 birds with a beak like this. 2 birds with a beak. When I was in UG, I used to remember it like bird is the beak. So 2 beaks will be attached, and in order to be active, this beak has to be activated. And when this is inactive, so it will be activated again by NAD. So this is glutathione peroxidase. This glutathione is completely important part of glutathione peroxidase. It will reduce this free radical. Now glutathione peroxidase will be actually this glutathione will be rejuvenated. So glutathione peroxidase, this glutathione will be rejuvenated by this enzyme glutathione reductase here. So this will be rejuvenated. This will be again used. So this cycle goes pathogenesis, because of here glutathione is very important. This NADH actually nullify this through glutathione. So this simple step, if you remember things in a very simple way, you will remember things. For example, the oxygen free radical that is from, you can call peroxide. The peroxide will be actually neutralized by NADH and ADPH through which? Through glutathione. And how does this glutathione is actually does this? Because glutathione is part of this enzyme. This is not complete integral part, but this actually is present in, it is like coenzyme, loosely bound. So it is part of enzyme, and this is also part of this enzyme. This is how it helps. So this enzyme actually use this glutathione to neutralize this, and then glutathione will be rejuvenated because of this. So reuse and rejuvenated like this. This is glutathione cycle, you can call it. So glutathione will be used by glutathione peroxidase and be rejuvenated by reductase. So use and recycle. Use, recycle. So you can call it use recycle cycle. And so activation is done by NADH, and use is done by this glutathione peroxidase to neutralize this. Now pathogenesis we have already done, because this RBC is exposed to oxygen. There is very high amount of oxygen, so there is a chance of production of free radical. So free radical will be neutralized by NADPH, and because there is deficiency, of glucose 6-phosphate, and therefore there will be deficiency of this, and then free radical will not be neutralized, and because of that membrane damage. If membrane damage, the membrane rupture means hemolytic anemia. So hemolysis due to membrane damage and hinge body formation. You can see hinge body formation is because of oxidative damage. Now this NADH not only protect membrane, but also it protects hemoglobin inside. So RBC has very high amount of production of NADH and glutathione. So glutathione NADH is very high. That is required to protect membrane plus hemoglobin. This, how would you diagnose this condition? So the peculiarities of this is bite cell. When you do peripheral smear, blood smear, so when you see what does this peripheral blood smear, you take out the blood from the patient and you put the blood on the slide and stain that blood, and you see that blood under microscope. So this is called peripheral blood smear. And then if you see that slide under microscope, in that slide you will see a bite cell bite. Why does it is formed? Because of a part of this RBC is engulfed by phagocytes. That is why this is bite cells. So bite cells will be there, and then irregular cell size, and then hinge body. Bite cell and hinge body are very peculiar to this, and because this is hemolytic anemia, means low RBC, when there is hemolysis, and this hemolysis will cause low RBC. This will cause low RBC, and then this low RBC will send signal to your kidney, because kidney will secrete now erythropoietin because of this low RBC, and this erythropoietin actually will activate the bone marrow erythropoiesis. Okay, in that process what will happen? If there is very low amount of RBC, there will be high amount of premature release of erythrocyte, there will be release of premature erythrocyte. This premature erythrocyte is called reticulocyte in blood. So blood, there will be, because of low RBC, there will be release of premature blood cells. This premature blood cell is called reticulocytes. Reticulocyte is nothing but RBC with very high amount of RNA. Okay, so RNA should not be there very high amount of, but RBC with very high amount of RNA is called reticulocyte. It's because of this RNA there will be reticulum formation. You can see that is why this is called reticulocyte. RBC with very high amount of this RNA is called reticulocyte. R for reticulocyte, R for RNA. Remember. So the very high amount of reticulocyte you will see because of low RBC content. Bite cell of RBC, this and reticulocyte. These two are very peculiar feature, and this is reticulocyte. You will see in other anemic condition also. You will see reticulocyte. This is a general presentation when in low RBC. And white Coombs test. So hemolytic anemia happens also because of immunoglobulin. So Coombs test, if this hemolytic anemia happens because of this immunoglobulin, then Coombs test will be positive. So if Coombs test is negative, that means this immunoglobulin is not destroying your RBC. So that is why Coombs test will be negative. And quantitative assessment of G6PD. So G6PD is present inside RBC. So you detect this, you check the assessment, you assess the activity of this in laboratory. So these three are the parameter. You do Coombs test, it should be negative, and then the activity of G6PD should be low, And the immediate test is you should see the peripheral smear. There will be bite cell and hinge body. These are the pathognomonic characteristics of this G6PD deficiency. And what is inheritance? Inheritance is a very good inheritance, like very famous, you have seen X-linked inheritance. That is why you can see a boy, a man. So man is affected more than woman. G6PD deficiency happens more in man. And then these are the presentation of anemia: pallor, fatigability, easy fatigue, headache, lethargy. So fatigability, lethargy, these are presentation of lack of oxygen, lack of RBC, and thus lack of oxygen. Now, because of breakdown of RBC, there will be jaundice. So you can see in this patient also, you can see jaundice. So some jaundice here, you see jaundice because of high degradation of RBC. So heme catabolism, heme will produce what? Bilirubin. So because of this, there will be in hemolytic anemia, there is high amount of jaundice. Hemolytic anemia, there will be jaundice. You know, hemolytic means prehepatic jaundice. So we will talk about this jaundice also. Dark urine, because of this jaundice, there will be dark urine. And history of exposure to some oxidant, like fava bean. So fava bean is a type of bean you can see here. So this fava bean, either patient consume fava bean or other oxidant. Other oxidants are, for example, drugs. We will talk about few drugs. I will give you a list of few drugs. And normally gives protection. Actually, this is a very, the G6PD deficiency has positive aspect also. In normal individual, G6PD gives protection against this Plasmodium falciparum infection. Okay, this is what Plasmodium falciparum malaria, cerebral malaria. So this is a very deadly malaria of all. So it gives protection against cerebral falciparum. You have Plasmodium falciparum. Okay, so these are the presentation. These are the everything. What is hinge body? So this is the hinge body. You can see when you stain this, it will, with supravital stain, it will look like this blue colored stain, hinge body. So hinge body, see, there is difference between stippling and hinge body. There are two types of same types of granulation. You will also see in stippling. Stippling happens in, stippling is feature of lead poisoning and thalassemia. Okay, thalassemia. So remember, there is two types. Similar type of presentation you will see also in stippling. Okay, stippling is a different thing. And here hinge body formation, you will see small this hinge body formation because of accumulation of this hemoglobin inside RBC. Inclusion within RBC, composed of denatured hemoglobin, you can understand, formed as a result of oxidative damage, because there is lack of oxidative protection against oxidative stress in G6PD deficiency. That is oxidative damage to hemoglobin. Macrophage is seen in spleen, remove denatured hemoglobin, and that is why I see hemoglobin, when it is removed by macrophage, so a part of hemoglobin will be eaten, and this will form a bite cell. You can see a bite cell, clear bite cell. So this is called bite. So it is like apple bite. When you put a bite on apple, it will look like this. So this is bite cell. Okay, and this is our hinge body. These are very pathognomonic of this presentation, G6PD deficiency. And see, if you have to differentiate G6PD deficiency versus what I told you, we have talked about pyruvate kinase deficiency. So pyruvate kinase also has hemolytic anemia, but pyruvate kinase will not have this bite cell and hinge body. Okay, pyruvate kinase will not have hinge body and bite cell. Pyruvate kinase, the age of onset is very chronic, and it is continuous, chronic and continuous. No association, you will not see association with any like factor, oxidant factor, that is stimulus. There is no any association of stimulus, for example, oxidant. It is continuous process, and generally you will see patient of lower age here in pyruvate kinase deficiency. Here you will see patient will have repeated episode because of exposure only, not normally. So normally it gives protection against malaria, okay? But when the patient is exposed to high oxidative stress, in that condition only G6PD deficiency will cause hemolytic anemia. So these are the very basic difference between this pyruvate kinase deficiency and G6PD deficiency. So remember, the when somebody tell you enzyme is absent, so it is not. Sometimes what happens is enzyme is mutated and enzyme is not very active, not 100% active as in normal. It will be active, but not 100%. It is also called deficiency. So here you will see there will be like activity. That is why this patient normally survives, but activity will not be optimal. That is why this patient will have hemolytic anemia when exposed to oxidative damage. So differentiate these two conditions: hemolytic anemia because of pyruvate kinase deficiency and hemolytic anemia because of G6PD deficiency. Now these are the drugs, oxidative drugs. These are the two important oxidative drugs. Okay, so anti-malarial drug. So you can see quinone type group of drug, quinone group of drug. You will study later. So anti-malarial is quinone group of drug. It has very high oxidative stress. And sulfonamide drug. This is also antibacterial drug.